Dr. Mary Jane Esplen is a professor at the Department of Psychiatry, Temerty Faculty of Medicine, University of Toronto, a former clinician scientist at University Health Network, and founded the Souza Institute, a national center for education for oncology health professionals. She has held career scientist awards from CIHR and NCIC for psychosocial oncology research, completing studies of psychotherapeutic treatments to support adjustments to being diagnosed with cancer, and receiving genetic risk information in breast, colorectal, and pancreatic cancer. Other areas of research include studies addressing body image among cancer survivors or the management of grief and loss. Dr. Esplen gives numerous workshops and keynotes and has received several awards, including the Lifetime Achievement Award from Canadian Association Psychosocial Oncology and the Bernard Fox Memorial Award from International Psycho-oncology Society. So thank you so much, Dr. Esplen. I'll hand it over to you in just one moment.
Thank you very much. You know, when you get diagnosed with cancer, regardless of prognosis or stage, there are just so many psychological stressors, medical stressors, psychological stressors. There can be financial for some folks. It impacts relationships and your partners or family members as well. In fact, you may be surprised sometimes when we measure psychosocial functioning or anxiety or, symptoms of depression or quality of life, they sometimes are even more distressed among a partner or family member. You may not know that, but there are 3 decades of research showing the impacts of being diagnosed. But people do well in general. We have done many studies now over the last 3 decades, following people over the long term. And the good news is that we're pretty resilient, most people. Majority of individuals, regardless of the cancer diagnosis, including your type of cancers, they do well after that initial adjustment period. However, depending when we measure our patients or family members, there can be pretty significant symptoms of anxiety, fear. There's a specific type of fear referred to as fear of recurrence. That's a very common and often very distressing fear that can linger for quite a long time. But we also measure depression and quality of life. But interestingly, and I've always been interested in this subset, there is always a smaller percentage, some around 25-30%, who have more persistent difficulties, even long after a diagnosis, even when the prognosis is good. I brought a couple of slides on needs. This is a Canadian study I wanted to show you, and it involves all kinds of different types of cancer survivors. And I don't know if you like that term. It's used a lot in the literature. I know that sometimes people don't relate to that term survivor, but it really means the time when treatment ends onward for the most part, or after the diagnosis. You can see that even over a long time, sometimes we have emotional concerns that might be anxiety or depression or worries, physical concerns because of the impacts. I'm going to come back to that. Practical concerns like returning to work, financial, logistics, if you have certain roles as a parent or other types of roles. And unmet needs are not that uncommon. Now, interestingly, young adults, we often look at groups and subgroups and try to understand who needs the most and who needs specific services. Young adults can be at higher risk when they're diagnosed. We have measured anxiety, this fear of recurrence, change in body image. You're going to hear a lot about it. That's a very prominent symptom and concern for the younger populations. But other concerns that are pretty common include fatigue, tiredness, hormonal issues or fertility changes, sexual functioning I'll come back to, and just changes in memory and concentration. These are the types of concerns that can linger on past the active treatment phase. Now let's get to body image. So why are we interested in that? Because I became interested in that. I mean, we were all measuring psychological functioning. But interestingly, I just want you to know all patients, regardless of the type of cancer, regardless of where the site is, you saw some pictures just a moment ago, regardless of the stage, everybody is going to experience some change in their body image. And I'm going to come back to that. And we know that it's important because poor body image, if it lingers significantly, is related to poor adjustment over time and also quality of life. And then there's this subgroup, a smaller group, we actually have a term called body image disturbance, which is a specific type of distress specific to body image related concerns. And this is important because body image is associated with quality of life. And we've recommended it is now part of a guideline to include it in health professionals who are doing quality of life and follow-ups in clinic. Now, in the area of skin, I'm not going to linger on this too long because you just had a whole talk about it. But this is just an example of one study. So patients with poor quality of life in this study showed more worries cognitively and concerns, more stress around how they were viewing their illness, experienced less social support, and had higher levels of symptom and anxiety, along with higher concerns of body image. So when they have poor quality of life, usually there are concerns around body image. We also know that body image mediates or plays a role in the relationship between your thoughts and concerns and how you experience your diagnosis and illness. And it mediates family stress as well as psychological symptoms such as anxiety and depression and quality of life. And you're going to hear more about this too. Social support is an excellent intervention because your relationships, your networks, your social friend support, family actually plays a role between psychological stress and quality of life. Now, what are the key issues? This is what I say to patients every time I give a talk, and medical professionals and nurses. Every single thing we do to a patient to treat them impacts their body and sense of self, everything. So for example, regardless of type of cancer, again, if you have surgical treatments of any type, you're going to end up with a scar or a change or a disfigurement, possibly, maybe a change in sensitivity or even bodily function. Most of our treatments can have an impact on sexual functioning. Chemotherapy, many of you will know, if you haven't been into menopause and you're a woman, you're going to go into premature earlier menopause. But chemotherapy has also been shown to have impacts such as fatigue and cognitive impacts, thinking. Hormonal retreatments can worsen menopausal symptoms such as vaginal dryness and also can have impacts on men. And radiation, another treatment used a lot, can affect changes in the skin, fatigue, body image, and so forth. So I actually had one of my randomized trials was body image after treatment for cancer. Can we fix what we've broken? And an oncologist came up with that title because we really believed in many ways what we do to cure cancer, which of course you want, has an impact on body image. And we need to help people with this. And you hear things. This is a young man with cancer, afraid of being sexually intimate. His prognosis is very good, but he's concerned because of scarring and changes in his sense of attractiveness. This is a woman undergoing chemo. She's lost her hair. Some of the treatments cause hair loss, of course. Her friend came over to see how she's doing, and she said she's been crying a lot. She's had a lot of changes, and she worries even how her hair will grow back. And I work a lot in breast and colorectal cancer, and I can tell you that even when women have mastectomy and lumpectomy and other changes in colorectal cancer, the hair loss for a lot of people is really significant. We don't want to underestimate it, and we don't want to minimize it and treat it as trivial because I did a whole intervention of a group therapy, and that issue came up a lot. You'll hear more about that. So our cancer treatments can create physical changes. They're real. So cognitive changes, scarring, reconstructive surgery is excellent. Of course, you often want it, and they do an excellent job, but it doesn't look the same. And sometimes your organs or areas of functioning or sensitivity will feel different. I have hysterectomy and other things on here because this is for all cancers. Some of the treatments cause, for some patients, weight loss or weight gain. People are different in how they experience the treatment. I mentioned the menopause prematurely, hormonal changes. Infertility is a big one for young patients. Lymphedema, that's a body image issue. And then even changes in skin like the burning or irritation or itching or, for some people may have to lose an eye. I know there are all kinds of impacts in our treatments in terms of the type of cancer you have. And then ongoing hair or loss or just even the change. So these are just examples. And we know that what these types of changes do is when you document it qualitatively or even in a large survey, people talk about, I feel less attractive or feminine or less masculine. I feel like I lost control over my body. And we know that that can relate to body image distress, which of course affects symptoms like quality of life. how your mood is, your depressive symptoms or fear and anxiety, and sexual functioning. So these are just some quotes from different studies, not that uncommon. And I wanted to, hold on, oh, it's okay. I'm feeling different. I don't look the same. I'm not attractive. It's changed how I feel about my role. I'm supposed to be the caregiver, not the receiver in the family. Sometimes I wonder if I'll be okay. I have a long life and I'm glad, and I can adjust to how I look or feel now. There are all kinds of variations in this. And I have to say that we have a very much model of care and treatment and survival, which of course we want. But in promoting that model, there are patients that are sometimes very shy or inhibited to come forward and talk about what they're really feeling about their sense of self and their bodies. And so it often is less unaddressed for many years. Now, how are body image problems identified or expressed? Here's some examples. You'll know this. I don't really need to put a slide up, but I'm just going to call them out. Distress over scars, and this can vary appearance or changes in function. Feeling sexually attractive or different sexually in terms of your functioning. Uncomfortable in revealing clothes. Sometimes patients who are avid swimmers or in sports, even though there's no reason why they can't return to that, they're not comfortable going back to a particular area of leisure and activity because they feel embarrassed or stigmatized or unattractive. Shame even. Avoidance of leisure activities or intimate relations with a partner, or even in the dating for those who are single. Feelings of less feminine or masculine, distress over carrying out a specific role, maybe not feeling as strong. And that was something that was part of your sense of self before. Being preoccupied. And you're wondering, when am I going to be able to turn this off? Like, I'm really looking at my body. I'm looking at this flaw. Like, it's really prominent in your thinking. You're really preoccupied or focused. And we definitely sometimes see that. And you don't know how to turn it off. And then a lot of time and effort spent on appearance fixing behaviors. Now, I'm okay with that. In fact, all those, those look good, feel good programs. And I think that's what it's called. There is a role for learning how to camouflage dress, even the cosmetic, the reconstructive, all the surgeries that are available. Those are interesting tools. They don't always help everybody and everything, but they can be useful. We'll come back to that. But if you're really spending a lot of time and a lot of money or effort on that, that might be a signifier you're having trouble with adjustment and acceptance. And then just having unrealistic expectations about the treatment outcomes around appearance and around your functioning. So education is really important when we're working with patients that are going through the treatments that you have to endure. It's really important that the physicians, nurses, and those of us in psychosocial care help support your education and know what to expect. It really makes a difference in how people feel after. Sexual functioning is one of the areas that which can be very persistent, sometimes several years after treatments end. And people are often very hesitant to come forward or not asked in your follow-up appointments about this. This is changing because over the last few years, there's been much more attention on trying to build in these types of services more or help physicians make referrals. But again, if the nurses and physicians aren't asking and you're not telling your care team, you may not be able to, and there are things you can do to get help with this, but it's one of the more silent areas, I would say. And these are the contributors to sexual functioning challenges. So some of those attractive physical changes, hair loss, loss of libido, changes in fertility, induced menopause, lack of vaginal lubrication, for example, or orgasmic response, changes to your actual body part or your organ, depending on where your cancer situation is, and distress around scars, lymphedema, and then again, weight gain. These are all contributing factors that can play a role in how somebody feels in sexual intimacy and whether or not they engage. And there's variation in it, but it's a range, but these are the contributing factors. So what is actually body image? Because people often think, well, it's just how I look. It's my physical sense of self. And I want you to maybe go away tonight knowing it's a little bit more comprehensive than that. It's multidimensional, and it has a sense of embodiment. Definitely is about your body, but it involves your perceptions, your attitudes about yourself, and especially your physical appearance. And there are more dimensions to that, because it's not just your attitudes, it's your sense of satisfaction or dissatisfaction with different aspects of your appearance, and how you actually add that up or evaluate it. Another factor is investment. You'll hear me talk about this later. How much value you placed on physical appearance and effort prior to your diagnosis, for example, and continue to do. Now, this is something that is often internalized through our culture and our families and our social experiences. And I can give you an example. I used to work in eating disorders, but for women, there's quite a lot of value placed on certain idealized women's sort of images, how we're supposed to look and feel about ourselves and our bodies. So that's often been imposed on us through Western culture. But men also have social factors. So those types of things for some individuals have really resulted in how much time, effort, and investment we place in that part of who we are. And people vary on this, but individuals that always had a little bit more of that are going to possibly have more adjustment issues. And then affect and feeling are the emotions you have associated with your body image and your sense of self. So that's how complex it is. This is a complex model. And what it's really showing at the top are the influence. So our cultures, our families, our socialization, our physical characteristics, what we're born with, our personality factors, and our experiences and relationships, including, I will say this, sexual, emotional, physical abuse or trauma in our past. These are things that all play a role in our body image schemas, which are our descriptors, how we view ourselves, how we would describe ourselves. On the left, the proximal influences are the situations in our life. That's your cancer diagnosis or the change or the surgery or whatever that's influencing our appearance and how we process how we see ourselves and feel about ourselves. And then that promotes along the bottom there, internal dialogue. Those are your thoughts, what you're saying about yourself to yourself, what you're feeling about yourself, what you're concluding about yourself. And when you're carrying all that around, and that's why during sexual relations, for example, when you have negative thoughts or you think you're unattractive or you think you're not strong or you want to hide yourself, that's going to interfere on the right-hand side with your adjustment, your emotions, your ability to even engage and feel free during sexual experiences and enjoy them, and in how you regulate your emotional mood and well-being and your behaviors. So you might avoid, you may not go to things, you may dress a certain way, you may not date. I mean, these are examples of behaviors where it can play a role. Now, another part I want to come to is this is kind of an existential impact of having cancer in general. So when we're experiencing in life any extreme experience, and in your case, I would say it is to be diagnosed with cancer. Cancer is often perceived like a life-threatening illness, even when your prognosis is good. Because I can tell you it's experienced differently, say, than a diagnosis of diabetes by many individuals. It's, the threat of cancer is often experienced as life-threatening. And a car accident's another example. Any jarring impact around something that's a threat interferes with our continuity of self. So I think about it a little bit like one of those horizontal escalators. We're going through life, we're just going along, and our self is a continuity of a self. And then something comes along and it causes an existential jarring interruption or impact. It stops us in our tracks, and you can end up looking back in your past and reflecting on your life, and you can be looking ahead, wondering what's ahead and how much is ahead and so forth. So it's kind of a jarring existential impact. That has been shown to change a sense of identity and self. For example, changes to your body or being kind of jarred like that when you're feeling healthy and everything was going okay, and then you're dealing with something like this. It can challenge your sense of life and central values, your priorities, they may shift. And we see this a lot where somebody all of a sudden, some areas of their life, like relationships or a job or not a job, become more important, or time with family is more important, or something else is more important, or something they haven't gotten to becomes more essential, valuable goal. They experience loss. This is very common among all patients. Either body parts, body functioning, or a change. That's a loss. So that requires, and it's going to involve grief and sadness and a sense of mourning, and that's completely normal and healthy to actually try to work and go through. And then there's a need to get back on that track, right? To restore, like our goals in therapy or treatments or any kind of curriculum or program to help people is to preserve that continuity. You know, you're going to go ahead. You know, the treatments end, or you're in treatments, or you're going forward. And how do you go forward? And trying to have, I often say, let's try to find what the cancer didn't take away, because I think patients can often lose sight of aspects of themselves that they're not recalling and not as salient to them, because they're so impacted and have been so jarred that we try to restore what's still there. And then through the survivorship or through going forward, you're going to learn more about yourself, new things about yourself. And that may be something we can tap into to help you recover and adjust. So people vary in how they manage this discontinued continuity. And we look for anchor points, and we look at people's beliefs and values and help them work through that. And then, you know, we're trying to achieve a sense of continuity again so that you can go forward in your life. Now, I'm going to skip that. Now, I want to talk about one more aspect, self-concept. So what is self-concept? So self-concept includes body image, and that's how we view ourselves as well. It's a sense of ourself as a person. So our self-esteem, who we are and our identity. So our role performances in work and at home, our identity, how we view ourselves, all of this contributes to a view of ourselves. And actually, we have these self schemas we carry around in our heads. So we have a sense of who we were in our past, who we are currently. And we also carry around, you know, way prior to the cancer diagnosis too, a future, how we see ourselves in the future, like how you may be when you're aging or how you may be down the road at a certain point. These are all things that we do. This is just normal part of self-concept, these self-schemas. And they get interrupted with the cancer experience and the treatments. And so when somebody, again, has an incongruence with how they perceive themselves, and then really their ideal self, if there's too much distance there, they can have more distress. And so our goals in treatments are to try to bring that sense of an ideal self closer to where you're at and try to find ways to bring them more in alignment. An ideal self, like to give you another example outside cancer, is when a woman is really viewing her ideal self in a very specific way. An ideal image in our culture, for example, might involve weight and a certain look and efforts to maintain all that, which are really hard to achieve. And so that can cause a lot of disturbance and distress over time when people have a discrepancy. So we know that people vary in this, and by Western culture standards, most women, but also men, have some aspects of a negative body image prior to any kind of illness. When there's a perceived discrepancy between an actual sense of who you are and when you're feeling inferior than a desired self, for example, that can relate to body shame, feelings of shame and embarrassment. Most individuals are going to experience some body shame in life and other types of areas related to gender. And we know that we've done studies on this. Individuals who came into this experience with cancer with specific kinds of images of themselves, particularly masculine or feminine, may have more difficulty in adjustment. And they may tend to do this self-objectification. I have a picture down there of a woman looking in a mirror, but they're scrutinizing and they're examining their bodies and they're looking at parts and they're zeroing in on a certain area. And this can cause quite a bit of distress. Now, what do we know about relationships? We know that when you have social support, including networks of friends and partners. It's very helpful. And partners' difficulty, though, can also be part of this, because sometimes the partner is also trying to adjust to a changed person or a changed body. They're part of it. And so understanding and support from partners are critical for cancer survivors to maintain healthy sexual functioning and their relationships. And there are things you can do to support that, including couple counseling. So what do we know in the research? We know that younger individuals may have more challenges, and when there is more severity of scarring and body image changes. Individuals with pre-existing relationship challenges, so people that in partners or marriages had more challenges prior to cancer, often have more difficulties in adjustment in this area. People that have undergone hormonal changes or menopause or other areas or treatments impacting sexual identity may be more challenged. And this is very important. People who have been in counseling in the past or had a mental health challenge or say a depression or anxiety disorder in the past, not for sure, but it could be a flag that they may need more supports going through treatments for cancer and the follow-up. And role of gender role, socialization, so that internalization of those ideals that are in our society. Now, how are we doing? You have a medical person and a psychosocial tonight, so that's more integrated. But often we're not addressing these in our clinics because I can tell you patients are pretty hesitant to bring some of it up, maybe in skin cancers and other areas, so that because it's such a focus on the body, it's coming up a little bit more. And we're really trying to work with physicians and nurses to ask more about the deeper issues. But again, we're very preoccupied and very happy with reconstructions and survivor outcomes. So I think that sometimes makes it less permitted to raise feelings when people are afraid to bring it up. And so it's dealt with often alone, and often when you're alone at night, and you may not even be talking to family, partners, or close friends. So what's needed? We need to look at ways to validate, first of all, your reactions and feelings of loss. They're all there. Even if you're not aware of them, at some point you're having at least some of them. We need strategies to support people in that continuity of self and to help them adapt to the changes and losses. And so any type of program or exercise or intervention that helps draw on who you were prior to cancer will help preserve some of that. And then we really look for ways to think about, what do you know about yourself now? What's emerging? Like, we try to find other ways to help construct that future self. Now, this is a bit small here, but recommended treatment. So let me go through these. We have kind of a range. So everybody's going to go through adjustment, and it's completely normal to have body image concerns. And we need to normalize that and make sure you know that that's common and to be expected. And we want to promote people to talk about it and open up about it and to set realistic expectations for your surgical and treatment outcomes. There are many ways to help with coping, and this is what we know from the research. Gradually exposing, for those who aren't looking, one of the factors associated with poor adjustment is actually avoidance. So not looking at it or not looking at a scar. Like I have worked with people with breast cancer who have never looked at their chest following treatment. I mean, they get dressed in the dark, they don't look at a mirror, they put their mirrors away. I mean, that's more extreme, but when you're seeing yourself engaging in avoidance type of behavior, not swimming again or not doing some things maybe you could do but you're afraid to, or feeling unattractive, that may be a signifier that you could use some help with coping and adjustment. Mind-body relaxation types of programs, mindfulness-based stress reduction, those have been done in randomized trials, guided image, any CBT, any type of group or wellspring program that may help with coping may help with this area. And then anything that helps with body image acceptance. So we use wellness programs, social activities. So people often feel, well, I'm going to build up with other parts of my body, or strength or exercise, or social interactions can actually make you feel better. And then cognitive behavioral therapy, guided imagery is something I've used in studies, mindfulness-based meditation, and trying to work again to mourning the lost, accepting, and then going forward. And there are treatments available in your cancer centers. You can ask for referral to psychosocial oncology. Appearance-related interventions can be helpful, and this is, again, just levels of it. The general population level is really about societal campaigns you see out there, around how we view our bodies in general. But targeted types of interventions by a trained professional, one-to-one counseling with a specialist, or couple counseling for a couple that's having some struggles, could be really helpful in this area to open up the issues, start to confront the losses, and work through the issues at hand. And we know this from trials. Walking, physical exercise, any of the wellness, eating healthy, any of these things can actually help you feel better about yourself. You don't have to get too fixated on it all, and you don't have to be extreme, but it actually does give people a sense of gaining some control. I'm getting near the end of time. I don't want to take too much more time. I did a randomized trial. I was telling you about it. It was in breast cancer, and I'm not going to go through the trial, but it was focused on guided imagery and group therapy. We brought people together in a group, and we used group support. We used information on how gender roles and socialization factors play a role in how we view ourselves even prior to cancer. And then we offered some guided imagery exercises to help confront loss, help promote those self-schemas going forward, and help explore their body image feelings to facilitate adjustment. And we also introduced the topics around sexuality. We had educational material, we talked about sexual challenges, and we worked with that in an 8 to 10 week program. And I'm just going to show you, and we did some guided imagery exercises, and I'm happy to share them. You can just write me. I'm happy to give you the scripts or the tapes if I can give you some tapes. But one of the exercises, I'm just going to walk through these quickly. We started out with relaxation exercises. So just, learning how to find an inner sanctuary inside and going inside and creating an inner serene, beautiful place to go and meditate and relax. And we worked over time with exercise that had the patients focus on themselves. And these were all patients after treatment, some of them even years after treatment, who were stuck. They were not really moving forward. They were not doing that well in body image. That was our primary outcome. And one of them involved having a person imagine themselves looking at themselves in a mirror and then taking off clothing and really examining the aspects of cancer. And that was the way to confront and start to, for people that hadn't really mourned or confronted some of the situations they had to face, I think that really promoted that. But there were some other exercises. But at the end of the time, we actually were able to change body image measures significantly. And we compared it to education alone, this group therapy. We changed a sense of body stigma and sense of feeling vulnerable. That's an aspect of body image, actually feeling vulnerable and different. And we changed quality of life. We improved sexual functioning, but it didn't reach statistical significance. And I think that's because it was too short. I think that just takes a little bit longer, but it was all moving in the right directions. This is an example. It was quite outstanding, this exercise for some. So if you look in the middle, this is a woman, and we asked, after we did the exercise in the group, what did they see? What did they experience in the guided imagery? This woman in the middle said, I could not see my whole body, only my hands. And we explored in the group about that. And she said, my hands are busy. I like to knit, and I'm creative. I have strong hands, and I knit a lot. And we sort of kept exploring with it. And it turned out she was a weaver. And I'm really cutting the story short, but she had such negative sense of herself until she did that exercise. And she didn't really look at her area, which was impacted by the cancer. She saw only her hands, which brought her back to an earlier part of herself, which had to do with creativity and what she creates and her power in that. And she ended up going forward. She did very well. Like it was almost like she forgot about that aspect of herself. And I'm just sharing that because that's an example of bringing something forward into the continuity of self and helping her go forward. And you never know what's going to come. We often have people that won't look at all. Like, it's very interesting, that exercise to do in a therapy. I wanted to end with this because I often get asked, do you think we can restore a sense of self and improve body image? And I say, yes, we can. It sometimes takes time, but yes, I think there are techniques and ways to get help with this. And I don't know if you know that you can ask for a referral. All cancer centers in Ontario, they all have psychosocial oncology departments and social workers or psychologists or psychiatrists. So you can always ask to talk to someone or obtain someone also through your family doctor or in the community. So I'll finish off there. Thank you again for giving me the opportunity.
Thank you so much, Dr. Esplen. That was wonderful and a very thorough and helpful presentation. So thank you so much.